you and I don't necessarily agree completely on this, or we come at it from different angles. Tissue-based testing versus liquid testing. And, you know, there are a lot of people coming and knocking on all of our doors saying they've got the best test. And it's really an amazingly rapidly evolving field. And I have to say, I really want a liquid biopsy to do the job. You know, I haven't really gone there yet in colorectal, in other diseases, I get it. And I know you kind of come at it from the other way, that you're I think, optimistic that this is going to be an impact. So are you using that in any way routinely for patients?
So the clear answer is not as routine. I would think from the practical standpoint, you know, you have those patients who come to you, you don't have enough tissue or you have issues and you want to take that decision on the spot. Think about your next patient with peritoneal carcinomatosis. And you think they're behaving like BRAF, but you don't have the tissue, no one has done that BRAF. Within 6 days, you can get your answer. Now, as with the lung cancer, our lung cancer colleagues, we understand that the presence of an alteration means it's present in the tissue. If it's absent, you can't definitely say that it's not. Then you have to rely on the tissue. But if I see a BRAF V600E mutation in the circulating free DNA, then I know the patient has circulating free DNA. That's about 70 to 80% likelihood of a match between the two. And so sometimes, and I've done that in a patient recently where I just, for the love of God, I couldn't find that tissue. We couldn't get it released, and I didn't have that answer. Guess what? The patient was V600A. So the patient went on FOLFIRINOX. Within less than a week, I was able to get that answer. The other place that I see this useful, and again, perhaps not yet in clinical practice, is to follow up certain clonal expansions, specifically RAS and others, because it tells me two things. One, we can understand when that emergence of resistance may happen, but the second is also that whole concept of re-challenge, where you may be able to reuse these EGFR inhibitors with about 20+ response rate when you see these RAS wild type re-emerging clones. So I think it has some utility. I can't say that I still think the tissue is the gold standard if you have enough of it and you're able to take your decision on the spot. When I do a liquid-based immediately, it's usually because I know the patient may be eligible for follow-up and maybe for trials, or when the tissue is not available.
Let's skip to the end maybe a little bit, because I know you're working very hard to run a study called COLOMATE, which is a sort of basket precision medicine, and we're very pleased to be helping and part of that. There you're going to really look at this issue of liquid versus tissue, but liquid biopsies would get you into that study too.
And tissue as well.
And tissue.
So both, but everyone will have both.
Yeah.
So you think about it, it's one house, 2 points of entry, and you don't know which one is the better point of entry. They may be the same, they may get you to the same place, or one may get you faster or what have you. So we're going to compare the two, but you get to the same point, which is essentially, it's almost a basket, or whatever you call them, bucket trials, and they have different names these days, platform, bucket, baskets. The point is that, you know, we're thinking about where do these patients fit. So there is for HER2, RAS mutated, FGFR altered, you know, an EGFR re-challenge arm, and the number of arms, and these are dynamic. You're a big part of that study. So that study will help us understand, one, whether we can truly match patients in colorectal cancer to a specific targeted agent when we find the target. And the second element is also establish the role of these liquid biopsies in a prospective fashion with tissue control. Thousands of patients will likely be on that study over the next few years, so that's an exciting part. Absolutely.